Welcome to the deep dive. Today, you and I are going to unpack a collection of information on something that might sound a little intimidating. Neoplasms of the oral cavity and jaws.
Hmm.
We've gathered a range of sources, think medical journal articles, detailed descriptions, and our goal is to pull out the really crucial insights. We want to give you a clear understanding of these growths, both the ones that, raise a red flag and the ones that are less concerning.
Right.
Consider this your fast track to getting well-informed on the topic.
Exactly. We're looking at all sorts of unusual cell growth that can happen in the mouth and jaw area. That includes everything from your lips and tongue to your gums, the floor of your mouth, the palate, inner cheeks, and even the jaw bones themselves.
Okay.
Some of these are what we call benign, meaning they aren't cancerous, they don't spread, while others are malignant. What we want to do is really clarify the key differences, highlight potential dangers, and explain what makes each type unique.
Okay, so let's dive right into the bone itself, the jaw bones. We'll start with malignancies of the jaws, and the first one up is osteosarcoma. Now that sounds like a mouthful, but let's break it down.
Yeah.
It's a malignant tumor that starts in the bone. And here's a surprising fact. It's actually the most common primary bone tumor overall.
Right, overall.
But here's where it gets really interesting for us, though it's actually quite rare in the jaws, making up only about 5% of all osteosarcomas. We're talking less than one case per 1.5 million people every year.
That's tiny. And what's fascinating there is that while osteosarcoma tends to occur in the longer bones, like, arms and legs, it very rarely decides to set up shop in the jaw bones.
Huh.
Our sources indicate the average age when it's diagnosed is around 35, but it can really happen at any point, from childhood all the way to old age.
Yeah.
The reported range is 8 to 85 years old.
Wow, huge range.
Yeah. It affects men and women roughly equally, with maybe a slight tendency to appear in the mandible, the lower jaw, a little more often than the maxilla, the upper jaw.
So, what might tip you off if this were happening? Well, common things to look for include swelling in the area, pain that might not go away, and something called paresthesia. That's that tingling or numb sensation you might get.
That numbness.
Yeah. There can also be what's described as an invasion of the periodontal ligament. Think of that as the tissue that anchors your teeth in your jaw.
Right, holding the tooth in place.
If that's affected, it can lead to your teeth becoming loose or even shifting out of place. Now, when doctors look at x-rays early on, they might see a widening of that space around the tooth root, the periodontal ligament space.
And if the tumor has progressed, the x-rays might show a moth-eaten appearance.
Yeah.
Imagine fabric with holes chewed through it. That's kind of what the bone can look like as it's being destroyed.
Right.
You might also see irregular radiopacities.
Yeah.
Radiolucent areas on an x-ray look darker, like something's missing, while radiopaque areas look lighter, indicating denser material. So these are like cloudy, denser areas within the bone. Sometimes you might hear about a sunray or sunburst appearance on the radiograph, but our sources emphasize that this isn't specific, It's not diagnostic just for osteosarcoma.
So you could see it elsewhere, too.
Exactly.
Now, the real defining characteristic of osteosarcoma is that the cancerous cells are actually producing osteoid. Think of osteoid as like the unhardened framework of bone tissue that gets mineralized later.
The precursor to bone.
Right. The most common subtype we see in the jaws is called chondroblastic osteosarcoma. As for what to expect in terms of treatment, it generally involves surgery to remove the tumor, often combined with chemotherapy and sometimes radiation. The encouraging news is that with the right treatment approach, the outlook, the prognosis, is generally quite good.
Okay, let's move on to chondrosarcoma. Again, the sarcoma tells us it's malignant, and chondro refers to cartilage. So this is a malignant bone tumor that starts from cartilaginous tissue.
Okay, cartilage, not bone itself.
Exactly, that flexible connective tissue. It's the third most common type of bone cancer overall. But just like osteosarcoma, it's pretty rare in the jaws, only about 1% of all chondrosarcomas in the whole skeleton.
What's interesting to note here is how these tumors tend to arise. Most seem to appear out of nowhere, what's called de novo.
It's pop-up.
Yeah. However, they can also develop from pre-existing benign or non-cancerous cartilaginous lesions, like osteochondromas or enchondromas.
Okay, so from something that was already there but wasn't cancer before.
Right. Our sources also point out a connection to certain genetic conditions. Individuals with Maffucci syndrome and Allier's disease have a higher likelihood of developing chondrosarcoma.
Oh, okay. Clinically, chondrosarcomas tend to favor the maxillofacial area, that's the upper jaw, and face more often than the mandible, the lower jaw. about 60% versus 40%.
Okay.
Specifically, in the maxilla, they often show up in the front part and the palate. In the mandible, the premolar molar regions, the very front symphysis, and that coronoid process near the angle of the jaw can be affected. The average age tends to be a bit older here, around 60.
60, okay. Symptoms can include a swelling that's often painless, an expansion of the bone, and as it grows, it can lead to loose teeth and dentures not fitting right.
That makes sense.
Depending on where it is and how far it spreads, people might also get pain, vision problems, nasal issues, even headaches. When doctors look at x-rays, these can have a really varied appearance. Might show that moth-eaten pattern, or they could look more uniformly cloudy, diffusely opaque.
What's fascinating is the potential for model densities within the tumor due to calcium deposits and ossification, where bone tissue develops.
Oh.
Sometimes you might also see that localized widening of the periodontal ligament space. For getting a really clear picture, though, CT scans are preferred. Now, when we look at these under a microscope, pathologists grade them from I to the 3 based on how differentiated the cells are. Grade I up means they still look quite a bit like normal cartilage cells.
Right.
Grade 3 indicates poorly differentiated cells. They look very abnormal, tend to be more aggressive. Interestingly, most jaw chondrosarcomas tend to be well differentiated, grade 1.
Now, here's a really crucial point about chondrosarcomas. They tend to be radioresistant. That means radiation therapy isn't typically very effective. Because of this, the main treatment is wide surgical excision. Surgeons aim to remove the whole tumor, ideally with a margin of healthy tissue.
Gotta get it all out.
Exactly. Unfortunately, the prognosis really depends on things like location, surgical success, and that grade. The 5-year survival rate can range from maybe 78% for grade I down to a much more concerning 22% for grade 3 tumors.
Big difference.
Yeah. Metastasis, or spread, usually to the lungs or bones, and local spread into vital structures are the main reasons this can become fatal.
Let's change direction now and talk about Burkitt's lymphoma. This is a highly aggressive type of non-Hodgkin's B-cell lymphoma. Lymphoma is cancer starting in the lymphatic system, part of the immune system, and B cells are specific white blood cells.
Okay.
Burkitt's is known for its incredibly rapid growth.
Yeah.
Interestingly, there are two main forms: endemic, mostly in Africa, and sporadic in non-African populations. And they present differently.
Okay, different types. The underlying cause involves a specific genetic translocation. Think of it like chromosomes swapping DNA pieces. In this case, it involves the c-Myc oncogene on chromosome 8 and the immunoglobulin heavy chain gene on 14. Oncogenes are genes that can promote cancer if mutated.
Right. There's also a strong link to the Epstein-Barr virus, EBV. This virus is associated with a very high percentage, like 95% of endemic cases, but only about 10% of the sporadic ones.
Wow, that's a huge difference.
It is. When we look at how these two forms show up clinically, the differences become clearer. Endemic Burkitt's is quite common in African children, making up about half of all childhood cancers in Africa. Typical age is 3 to 8, and it hits boys about twice as often as girls. It commonly involves the mandible, maxilla, and abdomen, with a particularly high rate of jaw involvement in very young kids, like 88% under age 3.
88%. Sporadic Burkitt's, on the other hand, is seen in North America and Western Europe, accounts for maybe 6 to 10% of childhood cancers there. Tends to affect a slightly older group. Average age 11, no real gender difference.
Okay.
A common way it presents is as a mass in the abdomen, often involving lymph nodes in the intestinal membrane or where the small and large intestines meet. Sometimes leads to bowel obstruction.
Right.
Jaw involvement is less common in the sporadic form, maybe 10% of cases. But when the jaw is affected in sporadic cases, toothache and that numb or tingling lip feeling, lip paresthesia, are common.
Radiographically, both forms tend to show that characteristic moth-eaten pattern of bone destruction we mentioned, with poorly defined edges.
Okay, same look there.
Yeah. Under the microscope, both types show medium-sized lymphocytes with round nuclei and small dark spots called nucleoli. A key feature is the starry sky appearance.
Starry sky.
Imagine a dark sky filled with stars.
Yeah.
It's the lymphocytes with numerous scattered macrophages, immune cells that have eaten cellular debris. These tumor cells also express specific B-cell markers and are dividing very rapidly.
Because it grows so quickly, a Burkitt's lymphoma is often very responsive to combination chemotherapy. The overall 2-year survival rate is around 55%, but this varies a lot depending on the stage. About 80% for low stage, only around 40% for advanced stages. Early diagnosis and starting aggressive treatment ASAP are really crucial.
Definitely. Now we come to Ewing sarcoma. This is another rare but highly malignant bone tumor, primarily in children and young adults. It's part of the Ewing sarcoma family, which includes primitive neuroectodermal tumors, or PNETs. These are characterized by small, round cells showing some features of nerve tissue.
Okay, small round cells. The exact cause isn't fully understood, but it's known to be associated with specific chromosomal translocations. The most common one involves chromosomes 11 and 22, fusing the EWS gene with the FLI1 gene.
Right, that EWS-FLI1 fusion. Clinically, Ewing's accounts for about 6 to 10% of primary malignant bone tumors, making it the second most common type of bone and soft tissue sarcoma in children.
Second most common in kids. Okay.
Most cases occur between ages 5 and 30, with an average age of 11 for head and neck cases, and it's slightly more common in males. Common symptoms include pain and swelling in the jaw. It can cause facial deformity, destroy the alveolar bone, the tooth-supporting bone, leading to loose teeth, and even cause ulcers in the mouth lining. On X-rays, it typically appears as a moth-eaten pattern of bone destruction with wearing away of the outer bone layer, cortical erosion, and sometimes a periosteel onion skin reaction. Like peeling layers off an onion, that's how the bone might look.
Onion skin, got it. When looked at under a microscope, Ewing sarcoma has uniform, closely packed small round cells with round to oval nuclei. The cytoplasm, the cell material, contains glycogen, which can be detected with special stains. A protein called CD99 is found in high levels in most Ewings. Because it can look like other small round cell tumors, diagnosis often requires extra tests, electron microscopy, immunohistochemistry for specific proteins, and cytogenetics for those chromosomal translocations.
Right, got to be sure. Ewing sarcoma is highly malignant and has a strong tendency to spread or metastasize, especially to the lungs, other bones, and lymph nodes. Treatment is intensive, usually surgery or radiation for the local tumor, and chemotherapy for systemic spread.
Intensive approach.
Yeah. While more intensive plans have improved survival, certain factors suggest a poorer outcome. Being under 10 at diagnosis, having metastasis at diagnosis, systemic symptoms like fever or weight loss, high inflammatory markers, and a high platelet count.
Okay, several negative factors there. Next, we need to discuss multiple myeloma. This is a cancer of plasma cells, those antibody-producing white blood cells in the bone marrow. In myeloma, these plasma cells become cancerous and multiply uncontrollably in the bone marrow, causing problems, especially in the bones.
Right, affects the bones.
It's uncommon before age 50. Average age at diagnosis is 63, slightly more common in men.
Clinically, patients often experience bone pain, especially back or ribs, due to osteolytic lesions areas where the cancer cells destroy bone. This bone destruction can also lead to swelling, bone expansion, numbness, loose teeth, and even pathologic fractures where bones break easily. Systemic symptoms can include weakness, weight loss, anemia, bleeding problems, more infections, and hyperviscosity syndromes where the blood gets too thick. Interestingly, in about 10% of patients, abnormal proteins deposit in organs like kidneys, heart, GI tract, liver, spleen. That's called amyloidosis.
Amyloidosis, okay. The hallmark radiographic finding in multiple myeloma is multiple, sharply defined, dark areas on X-rays called punched-out radiolucent lesions showing bone destruction.
Punched out like someone took a hole punch to the bone.
Exactly. This can happen in any bone, including the jaws. These jaw tumors can sometimes cause the bone to expand or, less commonly, create denser areas, osteosclerotic lesions.
Right.
In the lab, key findings include anemia with rouleau formation, red blood cells stacking like coins, and a monoclonal immunoglobulin, that abnormal antibody protein, in the serum and urine showing up as an M spike on electrophoresis.
The M spike.
Another important finding is Bence-Jones protein, specific parts of these abnormal antibodies found in the urine in about half of patients.
Under the microscope, multiple myeloma shows an overgrowth of those abnormal plasma cells in the bone marrow. Immunohistochemistry can confirm they're monoclonal, all from the same abnormal cell. These tests are crucial because it can look like other cancers sometimes.
Right, need that confirmation.
Treatment typically involves chemotherapy, often alkylating agents and steroids, radiation for painful bone lesions, and other therapies like bone marrow transplant, proteasome inhibitors, thalidomide-like drugs. Bisphosphonates are also used to help prevent fractures.
A lot of options there.
Yeah, but unfortunately the prognosis is generally less favorable, with survival times varying depending on the stage.
Now let's talk about a related but much rarer condition, solitary plasmacytoma of bone. As the name suggests, it's a single localized plasma cell tumor in one bone, without the widespread involvement of multiple myeloma.
Just one spot.
Right. Typically adults around 50, more common in men.
Symptoms usually involve pain and swelling at the tumor site. And like myeloma, pathologic fractures can occur. When it affects the jaws, it's often found in the angle of the mandible. Diagnosis relies on finding a single lytic lesion on a skeletal survey and confirming no widespread plasmacytosis in the bone marrow biopsy.
So check the whole skeleton in the marrow.
Exactly. On X-rays, it's typically a well-defined area of bone loss, sometimes with multiple compartments, and it can erode the outer bone layer.
Interestingly, routine blood tests are usually normal in solitary plasmacytoma, and that abnormal antibody protein, the monoclonal immunoglobulin, is only detected in serum or urine in about 25% of cases, much lower than in multiple myeloma.
Okay.
Microscopically, the tumor cells look very similar to multiple myeloma. Main treatment is local radiotherapy, usually very effective. Surgery might be an option sometimes, maybe followed by radiation. A really important thing to know about solitary plasmacytoma of bone is the significant risk, 30% to 75% of it, eventually progressing to multiple myeloma. But the overall survival, around 10 years average, is generally better than established multiple myeloma.
Okay, so a risk of progression, but better initial outlook. Finally, in our discussion of bone malignancies, we need to cover metastatic carcinoma. This is cancer that started somewhere else and spread to the jaw bones.
Spread from another site.
Right. While relatively uncommon in the jaws, about 1% of jaw cancers, it can be a significant finding, sometimes even the first sign of cancer elsewhere.
It's more frequently found in the mandible, the lower jaw, about 80%, than the maxilla, upper jaw, 14%. In adults, common primary sites are breast in women, lung in men. Others include prostate, GI tract, kidney, colon rectum. In children, neuroblastoma is the most common primary site that metastasizes to the jaws.
Symptoms can include bone pain in the jaw, loose teeth, numb lip, jaw swelling, a gingival mass, pathologic fractures, and as we said, sometimes it's the very first sign someone has cancer somewhere else.
Wow, first sign in the jaw.
Yeah. On X-rays, most metastases look like poorly defined, dark radiolucent defects, indicating bone destruction. However, some cancers that spread, like from prostate and thyroid, can actually cause new bone formation, resulting in denser, wider radiopaque lesions.
So some destroy bone, some build it up.
Exactly.
Yeah.
It's important to distinguish it from things like osteomyelitis, bone infection, which can also look moth-eaten, but usually doesn't expand the bone as much.
Because the microscopic appearance depends on the original cancer, pathologists use immunohistochemistry to help diagnose. Looking for specific proteins like cytokeratin, CK7, CK20 can give clues about the origin.
Finding the primary site is key for treatment. If the jaw metastasis is isolated, surgery or chemoradiation might be used locally. But if it's widespread, treatment is usually palliative, managing symptoms, improving quality of life.
Right.
Unfortunately, the prognosis for metastatic carcinoma to the jaws is generally poor. Only about a 10% 5-year survival rate. Most patients die within a year.
Very tough prognosis. Okay, let's move on to a different category. Lymphatic neoplasms. Lymphoma is cancer starting in the lymphatic system cells, part of the immune system, broadly classified into Hodgkin's and non-Hodgkin's lymphoma.
Right. Hodgkin's lymphoma is distinguished by the presence of Reed-Sternberg cells, large abnormal lymphocytes. While it primarily affects lymph nodes, it can also involve lymphoid tissue elsewhere, called extranodal sites. It has an interesting age pattern. Peaks in young adults, 15-35, and again in older adults, 55.
The most common symptom is painless swelling of lymph nodes, neck, armpits, groin. Other symptoms can include unexplained fever, night sweats, weight loss, fatigue. While less common, Hodgkin's can sometimes involve extranodal sites like the spleen, liver, bone marrow, and very rarely the oral cavity.
Diagnosis relies on finding those Reed-Sternberg cells in a biopsy, usually of an enlarged lymph node. Imaging like CT and PD scans are used for staging how far it spread using the Ann Arbor system, stage 1 to biopsy.
Treatment depends on the stage. Localized disease might get radiation alone. Advanced stages often need chemo, sometimes with radiation. Stem cell transplant might be used for relapse or refractory disease. Generally, the outlook for early stage Hodgkin's is very good, high cure rates. Advanced stage is more variable.
Non-Hodgkin's lymphoma, or NHL, is actually more common and much more diverse. Also originates in lymphoid tissues, but characterized by uncontrolled lymphocyte growth without Reed-Sternberg cells.
No Reed-Sternberg cells, okay.
NHL is classified by the lymphocyte type affected B cells most common, TNK cells less so, and by tumor behavior from slow-growing, indolent, to very aggressive.
Mm-hmm.
Burkitt's, which we discussed, is an aggressive B-cell NHL.
Right. Clinically, NHL can show up as painless lymph node enlargement or a mass in extranodal sites like the GI tract, skin, CNS.
Mm-hmm.
Systemic symptoms like fever, night sweats, weight loss can also occur. Interestingly, up to 40% start in extranodal sites, GI tract being most common. In the head and neck, Waldeyer's ring, that lymphoid tissue in the throat, is often involved. Diagnosis is via tissue biopsy with immunohistochemistry. And arbor staging is also used.
Treatment can include radiation for localized disease, but chemo is often the main treatment, especially for widespread or aggressive types. Biologic therapies like monoclonal antibodies targeting lymphoma cells, for example, rituximab for B cells, are also increasingly used, often with chemo.
Okay, lots of options there too. Let's now shift focus to ulcerative neoplasms of the oral cavity. The most common here is squamous cell carcinoma, or SCC.
Right, SCC.
Cancer from the squamous cells lining the oral cavity. Significant malignancy, about 3% of male cancers, 2% of female, higher in men.
The leading cause is tobacco use. All forms: cigarettes, cigars, pipes, smokeless. Alcohol is another major risk factor, and its effects are amplified with tobacco.
Synergy there.
Definitely. Other factors include infection with certain HPV types, especially 16-18, poor nutrition, chronic irritation, weak immune system. Oral SCC develops through genetic mutations leading to uncontrolled growth.
Clinically, SCC can appear in various spots. On the lips, lower lip more common, linked to UV light and pipe use. Presents as a non-healing sore or ulcer, or an outward growth, exophytic. Inside the mouth, the tongue, especially sides, underside towards the back, is most frequent. Can be asymptomatic early on, then cause pain or difficulty swallowing. Floor of the mouth is second most common, often a painless, non-healing ulcer or red-white patches.
Okay.
Inner cheeks, buccal mucosa, and gums, gingiva, affected about 10% of the time. Palate is less common.
Under a microscope, most oral SCCs are moderately to well differentiated. They still resemble normal squamous cells somewhat, might form keratin pearls or show individual cell keratinization. Poorly differentiated lesions look much less normal, tend to be more aggressive.
Diagnosis confirmed by biopsy and histopathological exam. Imaging, CT, MRI, PET, helps determine extent and spread. Treatment can involve surgery, radiation, chemo, often combined, depends on tumor size, location, stage, patient health. Prognosis highly dependent on stage. Early stage, maybe 60–70%, 5-year survival. Advanced stage with regional spread, maybe down to 25%.
Big drop.
Yeah. Treatment can also have side effects: dry mouth, xerostomia, mucositis, inflammation, osteoradionecrosis, bone damage from radiation.
Another important ulcerative neoplasm is basal cell carcinoma, BCC. Actually, the most common skin cancer overall, primarily affects older adults, originates from basal cells in the epidermis, most frequent on sun-exposed areas: face, neck, arms.
Most common skin cancer, okay. Main cause is prolonged UV exposure, sun, or tanning beds. Other risks: fair skin hair rays, sunburn history, chronic sun exposure, older age, male, certain inherited conditions like Gorlin-Gold syndrome.
Clinically, BCC is typically a slow-growing, painless lesion, several forms. Nodule ulcerative, pearly nodule, visible blood vessels, might ulcerate, pigmented like nodular but with melanin, superficial, scaly red patch, and fibrosing morphiform, look like a scar, firm, yellowish.
Different looks. Microscopically, BCC shows cluster strands of basiloid cells from the epidermis basal layer. Often peripheral palisading cells at the edge line up.
Diagnosis confirmed by skin biopsy. Dermoscopy helps too. Shows branching blood vessels, blue-gray nests.
Right.
Treatment depends on size, location, subtype. Options include surgical excision, Mohs surgery, precise layer-by-layer removal, cryosurgery freezing, electrosurgery, topical treatments for superficial types, radiation.
Prognosis for BCC is generally excellent, slow-growing, rarely spreads, but can cause significant local damage if untreated.
Now let's delve into verrucous carcinoma, a somewhat unique SCC variant. Well-differentiated, slow-growing, locally destructive, but rarely metastasizes. Strong link to smokeless tobacco, HPV role suspected but not proven definitively.
Smokeless tobacco link accounts for about 5% of intraoral SCCs, common on buccal mucosa, gingiva, tongue, palate, mainly males over 50.
In early stages, looks like a white bumpy lesion, resembles benign verrucous hyperplasia. Progresses to a prominent whitish-gray, rough, shaggy surface. Microscopically, shows thickened, highly keratinized epithelium, bulbous masses extending down, but with smooth, pushing borders, not irregular invasion like typical SCC. Importantly, cells don't show significant atypia abnormalities.
Pushing borders, less cellular abnormality. Primary treatment is surgical excision. Radiation less common, partly due to historical concerns about making it more aggressive, though maybe viable sometimes now.
Prognosis is generally excellent due to high differentiation and low metastasis risk. Local recurrence possible, if not all removed.
Okay, good prognosis mostly. Finally, we have actinic cheilitis or solar cheilitis. This is a precancerous condition of the lips caused by long-term UV exposure, mainly sun. Most common in fair-skinned people, often outdoors.
Cumulative UV damage.
Rest.
Risks. Fair skin hairlines, chronic sun exposure, outdoor work hobbies, sunburn history, older age, male.
Typically affects the lower lip more, gets more sun. Clinically can show dryness, scaling, redness, swelling, loss of the sharp lip border, vermilion border. Might see white grayish plaques, fissures, thinning, thickening, even ulceration crusting.
When biopsied, can show hyperkeratosis, parakeratosis, dysplasia, those abnormal precancerous cells, and solar elastosis, sun damage to elastic fibers.
Diagnosis is mainly clinical appearance, sun history. Biopsy confirms dysplasia, rules out SCC if there are suspicious areas like ulcers or hardened spots.
Right, got to check those spots. Goal of treatment is to prevent progression to SCC. Involves strict sun protection, topical treatments, 5-FU, imicamod, cryotherapy, laser, photodynamic therapy, or surgical excision for concerning areas.
With good sun protection and treatment, prognosis is generally good. Doesn't usually progress to SCC.
Okay.
So as we've journeyed through this information, you can see that the specter of neoplasms affecting the oral cavity and jaws is incredibly wide. We've highlighted the critical distinctions between benign and malignant, bone versus soft tissue origins, and the significant role of genetics, environment, and lifestyle choices.
Absolutely. And it truly underscores the importance of being attentive to any unusual signs or symptoms in your mouth and jaw area, and the vital role that diagnostic tools play. Radiographic imaging, microscopic analysis, they help us understand what's happening at a cellular level.
Yeah.
Early recognition and appropriate intervention are absolutely crucial in managing this diverse range of conditions.
This deep dive leaves us with a thought-provoking question for you. Considering the sheer variety of these neoplasms and the sometimes vastly different prognosis, what does this tell us about the incredibly complex nature of cellular growth within our bodies and the intricate ways our systems respond when that growth becomes uncontrolled? It certainly encourages a deeper appreciation for the ongoing research into the precise mechanisms driving cancer development and the continuous advancements being made in treatment strategies. Thanks for taking this comprehensive, if somewhat dense, deep dive with us.